Next one will go to Dr. Ekta Shaw. Okay. Now, Dr. Ekta Shaw, you can speak on your topic, evaluation of surgical outcome of 360 degrees goniotomy in primary congenital glaucoma.
Good morning, everyone. I'd like to present my work on evaluation of the surgical outcomes of 360-degree goniotomy in primary congenital glaucoma. Now, primary congenital glaucoma accounts for around 0.01 to 0.04% of the blindness worldwide, and the definitive management is surgical in this case with these following options. Now, goniotomy is preferred to other surgical options. Why? Because it is minimally invasive, it spares the conjunctiva, and it is also cost effective. The traditionally angle surgeries which has been described, they open up about one third of the angle, but the so multiple surgeries might be needed to open up the entire angle. So we perform this prospective analysis on the surgical outcomes of 360-degree goniotomy. Now we included around 52 eyes of 32 patients which were presented to our clinic, and patients with PCG with age less than 2 years with good corneal clarity, so we can see the angle, were included, and patients with the following exclusion criteria were not included. Now I'll show you the procedure. First, nasal goniotomy is performed using 24 gauge cannula. As we can see that as the iris is falling back and there is opening up of the angle, we can see this, and then side is changed, and then we perform the temporal goniotomy. And following that, irrigation aspiration is done, and thus we complete the 360-degree goniotomy. Next, we can see that the gonioscopic view of the angle pre and post-op. In the pre-op, we can see that there is anterior insertion of iris, and after goniotomy, the iris can be seen falling back with the opening up of the cleft. The patients were followed up for a period of 1 year every 3 monthly, and we recorded the IOP and the number of anti-glaucoma medications of the patients, and we defined the criteria of success as absolute and qualified success. And now we show, coming to the results, we see that we have plotted the IOP in the pre-op 3 months, 6 months, 9 months and 12 months. We can see that there is decrease in the mean IOP in this along this entire duration with a significant p-value. Also, we can see that the number of anti-glaucoma medication has significantly reduced along the period of 12 months. We also plotted the baseline characteristics like the age, the intraocular pressure, axial and corneal diameter, and anti-glaucoma medication, and the cup to disc ratio of the patients. This is a chart which shows the trend in the intraocular pressure and the anti-glaucoma medication. As we see that the anti-glaucoma medication seem to decline over a period of 12 months, and also the IOP seems to be falling low along this period. And we plotted a correlation between the IOP and the cupping and axial, but there was no significant result we found. Now, the success rates were complete success of 40% and qualified success was 48%. We plotted the Kaplan-Meier survival analysis, and we see that the plot becomes flattened after a period of time, and additional surgery was required only 9.61% patient, and complication was only seen in 19.23% of the eyes. Now, why goniotomy? Because it is conjunctival sparing, shorter duration, lesser complication. Why 360-degree goniotomy? Because there is reduced parental stress, aqueous outflow channel is not symmetrical, so if we treat entire angle in one go, it is better, and multiple need of anesthesia is reduced. Also, it is cost effective in a country like ours. Now, various studies have been performed comparing others like trabeculotomy has been performed, and there was study which correlated this 360-degree versus traditional, but they have added good results with trabeculotomy, but the trabeculotomy has additional cost of the microcatheter. Also, if you perform trabeculectomy, it uses the conjunctiva. There is manipulation of conjunctiva, use of anti-metabolite, and there are blood related complications. So therefore goniotomy appears to be safer. We have various studies which compared this thing, and I'd like to conclude that patients with PCG, they require multiple surgeries. So in our study, we found that the patients undergoing goniotomy were able to maintain the IOP for a longer period of time. So this highlights the benefits of circumferential goniotomy, where the entire angle is treated at one go with significant lowering of IOP and number of anti-glaucoma medications. Thus, this buys time for further intervention if it fails in future. Thank you.
Baseline IOPs were 24 plus minus 6, you said. So did you
Yes, ma'am. Yes, ma'am.
It would have been
Yes, ma'am. Yes.
So
When
what
the
was that?
baseline pressure was lower, the pressure reduction was also on the lower side. We
That
noticed.
patient responded in a better way.
Yes, ma'am. Yes, yes, ma'am. But yes.
What was the maximum pressure reduction that took place in your study?
The maximum pressure reduction which was noted,
Yeah. Yeah, which was noted here.
yeah, sir, it was around 20 to 30% pressure reduction was noted, the maximum,
The
which
maximum.
is obviously in a very few number. Also, the sample size is not very much. We are conducting and we would like to present our results with a larger sample size, sir.
Just one question. You're sitting temporarily and doing the nasal.
Yes, ma'am.
And then
Then we have to change the site, ma'am. So the surgeon is sitting first temporarily and doing the nasal goniotomy, including the superior and inferior as much as we can. Then the surgeon changes the site, and then we change the position of the patient also and the microscope also, and then we.
can you do it sitting from the other side, or you need to sort of stand?
No, 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 ma'am, no need to stand. We can do it. Just we have to change the position of the head of the baby as well as the microscope. It is slightly time taking, but it could be done. Yes, ma'am. Yes, ma'am.